Hello, CAM followers. We are here again today. This is the lovely Gwen. We had an amazing chat last night. So please do realise that this is part 2 of a 2-part series. So part 1 was last night and it was really fantastic. Really enjoyed myself. Please meet the lovely Dr. Gwen Covey Crump. But first of all, I would just like to say a thank you to the sponsors for tonight. So thank you, Animal Care, who are making this happen. It's a really important topic that they are basically helping all of us understand to a greater degree. They are the manufacturers of a new non-steroidal that's out called Daxocox. It's a 7-day duration, and it's certainly another part of the toolkit towards us managing this really complex disease. So let's pop you away. Please, Gwen, tell people about yourself so they have faith in everything that you say.
So if you weren't watching last night, I'm Gwen Covey Crump. I'm a specialist in anaesthesia and analgesia, so add that to anaesthetics and pain management. And I run a pain clinic, a chronic pain clinic in Bristol for Langford Vets, and I also speak about chronic pain quite a lot to anyone who'll listen to me. And then other times I'm doing anaesthetics. So that's my main professional role.
Very busy. And she works with us at CAM. She's one of the CAM advisors. And an absolute blatant plug is that me and Gwen do practice trainings together. So one of the things that we really enjoy doing is going into practices. We train the whole team. So that is reception, nurses, and vets. We tackle up to 70-80 people. We've done teams of 70 to 80 people in one day. We're doing a practice in Australia this weekend. We're doing a practice in Yeovil. We're doing a practice up in Yorkshire. So it's becoming more and more popular. So please do get in touch if you want us to come to your premises. Right. So yesterday we were talking about breakthrough pain, and we're just going to do a quick summary for those of you that didn't catch yesterday. So breakthrough pain, what is it? It's an abrupt, short-lived and intense pain that breaks through the around-the-clock analgesia that controls the persistent pain. So we're talking about animals that have periods of flare, periods of pain that analgesic protocol, that pain relief protocol can't quite control. Something that I wanted you guys to take away from yesterday is that we really need to start thinking about osteoarthritis not just as a chronic pain condition, but as an acute on chronic symptomatic condition. Acute flares, these breakthroughs, are common. And just because your dog is on a baseline intervention, such as a non-steroidal, it doesn't mean that they're going to be shielded from these episodes. It is absolutely possible that they could be having episodes, being them short points during the day or being longer periods. We do know that there's not very much in the literature about dogs, so we do have to extrapolate quite a lot from humans. And areas that have been recognized as potential underlying areas of concern are incident. So these are trauma-associated acute flares or breakthroughs. Idiopathic, where we have no underlying cause known, and end of dose failure. So the pharmaceutical plan that animal is on isn't being maintained. It isn't sufficient, and it drops down and means that animal's pain state can break through that level. But Gwen's going to be able to talk about that much more. We wanted to really highlight that breakthrough pain isn't just due to musculoskeletal disease. It can occur in all forms of pain. So that can be organ-related disease. It can be neurological, neuropathic-related disease. Areas that we can really make a difference is going to be in owner compliance and also potentially disease progression. So that's a summary of yesterday. Today, we are going to be talking about avoidance of breakthrough pain, as well as actions that need to be taken in times of breakthrough pain. There you go. I'm going to stop talking. Over to Gwen. She can do everything now. So avoidance of breakthrough pain, the key player in this, you're already doing it. Anybody that's listening to this, you're educating yourself. And this is really important in that if you don't know it exists, you're not going to be able to do anything about it. But educating owners about the fact that breakthrough pain exists in the form of incidental, so trauma associated. That means exercise, impact activities, repetitive strain, recurrent, inappropriate impact forces on those vulnerable joints. Letting them know about end of dose plasma levels, so making them aware that that medication that dog's on might not maintain them. It isn't like Danger Mouse and the shield of steel. Just because they're on it doesn't mean it's going to be there consistently. Animals can break through that. And also to help owners identify these breakthroughs as well as identify progression. So I'm going to let Gwen have some talk time. And she's going to talk to us about pain and about the pathophysiology of pain, about the pain pathway, and about something that I think everybody should know about, which is central sensitization. So over to you, Gwen.
So we did mention it a little bit last night, didn't we? The difference between an injury, just getting an injury and the pain you suffer from an injury and then during the healing period, and something like osteoarthritis, is that you can develop what's called central sensitization, as Hannah says. So if you have a continuous painful stimulus or a focus of inflammation, like our osteoarthritis, then that focus is effectively sending nerve signals from the joint where the pain is occurring or the inflammation is occurring, up to the spinal cord, which is where the nerves sort of junction into the main highway. And then in the spinal cord, some funky things happen. So in a normal pain situation, if you have an acute injury, then to a certain degree, pain is suppressed by the spinal cord and ultimately levels up to the brainstem at the bottom of the brain. And that is a survival mechanism. So you've heard stories about people getting themselves out of emergency disaster situations despite having broken legs or horrendous injuries, and then flopping afterwards with the pain and suffering the pain afterwards. So we have an incredible ability to suppress pain in order to survive. But those mechanisms don't work so well when we're talking about chronic pain. So we've got more of a sort of low-grade, insidious chronic pain rather than this very severe acute pain like you get in an injury. And this is constantly sending these signals up to the spinal cord, this main highway, and actually irritating the nerves in the spinal cord to the extent that they become hyper-excitable, hyper-irritable, and more likely to fire their signals up to the brain. And then if it carries on, so that's what we call that central sensitization. It amplifies the signal, the experience the animal has of the pain. And if it carries on untreated, then we can actually get changes up in the brain and in the brainstem, which start to damage the body's ability to suppress that pain, which is what the body's designed to do, is to suppress pain to a certain extent. And that just really starts to break down with chronic pain. If you've looked into pain to any extent, you will have heard about descending modulation of pain, so inhibition of pain via signals that are coming from the brain. And it's all very, very clever and very complex, but that doesn't work so well in quite a lot of animals with chronic pain. And once all these processes are in place, it's quite hard to reverse it. So this is what happens if we don't treat chronic pain, if we just let it carry on and let animals manage. And the problem is, if a dog has an acute injury, like a tendon injury or a fracture, it's going to be lame. It's going to be really obvious. It's going to probably cry out in pain. It's going to be really obvious it needs treatment. But something like osteoarthritis comes on really slowly and gradually over several years. And so we often don't notice it. And quite often they're not lame. They're painful. They can be painful before they become lame, especially if it's in more than one joint. So this is what I see quite a lot. Dogs with both elbows affected, they don't know which leg to limp on. So, if you're experienced in watching dogs with arthritis walk as a vet, I can see they're not walking normally, but because they're not actually limping, the owner can't see that they're not walking normally. And And so it can take quite a long time for you to notice that there's a problem there and present your dog to the vet, which means it's not being treated. So, and I think that's the other thing regarding breakthrough pain, is that a dog can be on pain relief, but because this is a fluctuating disease, and they can do things like, we talk about this incident, so overdoing it in the park, chasing a ball that somebody else threw, not you, hopefully. Going off after a rabbit because the excitement of the moment is far overrides any pain they're experiencing, and they suffer for it later. So these can cause the breakthrough pain that we're talking about tonight. And if we don't treat those episodes of breakthrough pain, then we're still probably allowing this central sensitization to occur, this sort of wind-up irritation.
Which is going to be harder to control. And I think,
yes,
keeping it ridiculously simple, I'm going to quote you on something that you said many years ago to me, that the pain buds away and becomes its own disease. And I think that's really helpful for people to understand, is that effectively you go from osteoarthritis to osteoarthritis, and I've now got to control the nervous system because it's doing its own thing. And I think people really need to understand that. That's why we use multiple medications and multiple interventions, because many of these dogs that we see have been suffering for a significant amount of time. They are wound up, they are centrally sensitized, and there's no way in the world one thing is going to do all of the work. That's just impossible. So we collectively, as dog owners, dog lovers, we've got to really ramp up identifying these cases earlier and teaching people about how pain is expressed and how common it is. I think one thing, and another thing that I mentioned, lovely Lindsay. Lindsay did a course with me once, and she phoned me and said, "Oh my God, it's like I see ghosts, like Sixth Sense." When the kid goes, "I see them everywhere." And she, having done this course and learnt about postural change, learnt about physical changes, learnt about gait changes, she goes out for a walk in the park and she's like, "Oh, there's one. Oh, there's another one. Oh, there's another one." And you just start seeing it everywhere.
Do you have a warning? Do you have a warning with your course that once you see this, you cannot unsee it?
I know. The amount of people that do module 1 and kind of email me going, "I'm crying. Thank you." But no, it is really prevalent. It is really, really common. And we really should be trying to attend to it earlier. So synopsis, unmanaged pain is not great for the dog, a lot harder to control. So by trying to get ahead of the game, we're going to get better long-term results. So moving on our agenda, because we're so organized today, we talked about the pathophysiology, and we've talked about explaining central sensitization. I think now let's talk about how to identify it, and just kind of give people a few pointers, because reading about it and hearing about it, you're like, would I ever detect it? And your video of Dottie was something that just blew me away, probably about 6 years ago, was it? And you're stroking Dottie and she just steps away, skin crawls, just looks slightly, whites of the eyes, in the same location. Can you explain that video to the followers?
Yeah, that it must have been 5 or 6 years ago. She my previous dog, I struggled to manage her pain. Her pain wasn't arthritis, actually. I struggled to work out why she was painful, but she lost an awful lot of muscle through use of steroids, because she had a nasty sort of type of blood cancer, which she recovered from, but she never recovered from losing all this muscle mass. And I think because she didn't use her muscles correctly, because they were so wasted, then she got this muscular pain, myofascial pain we call it, and it was really hard to treat, and I couldn't treat it effectively. But one day I was grooming her, and I suddenly noticed that I got a certain way down her back and she kept stepping away. She would just step away, and then if I kept doing it, then and I did at one point actually notice, as you said, her skin twitched. And then I noticed that she was licking her lips. So she was anxious, and she'd never been anxious about being groomed before. So this is so I was doing something that to her that shouldn't have been painful. In the past, she'd never minded me doing, but now all of a sudden she's showing me the behavioural signs that it's uncomfortable. So she can't actually say to me, "That's really uncomfortable. Please, can you not do it?" So we have to look for the behavioural signs that it's discomfort. Any sign. The way an animal communicates with us is through the way it behaves. Yeah.
Yeah,
so
totally.
Behavioural signs of pain as vets, and this is called this something becoming painful that's normally not painful is called allodynia, which is a technical term for that experience of discomfort, of pain with something that shouldn't be painful. So sort of light touch of the skin, stroking. Actually, allodynia also covers things like sunburn. So if you get sunburn, your skin feels really sore. You can step in the shower. Sometimes you don't even realise you've got sunburn until you step in the shower, and all of a sudden the shower feels like it's red hot just on that area of sunburn. And that's actually allodynia as well. So it can be an area where the tissue is damaged, or it can be an area where the tissue is not damaged. And in Dottie's case, it wasn't damaged. It's just she had this central sensitization, which had rewired her central nervous system at the spinal cord level to actually find something that was just light touch, had become painful because those light touch nerves had got cross-wired with the pain nerves. Which is a simple way of saying something extremely complex that I can't explain because it's too complex.
No, it is really complicated. I'm Captain Simple. And, I think when you said rewiring, it's a really good way of putting it, in that you have these fiber types, these nerve types that carry different information to the brain, be it touch, be it temperature, be it pain. And they should go to their certain points, their certain connector points, to take that same information up to the brain. So touch to touch, pain to pain, temperature to temperature. But as Gwen was saying, they almost get cross-wired, and touch goes up and it jumps over into the pain pathway to the brain. So what should have been just a light touch or a movement is now interpreted as painful. And going back to how do we recognize it? I love Sarah Heath's approach to this, talking about the 4 behavioral responses, where you've got avoidance, inhibition, aversion, and appeasement. And you can see a mixture of them, you can see one of them, but there's us always thinking it's going to be an aversive type behavioral response. They're going to tell us. But actually they could go, "Oh, no, don't touch me there." Or they could be like, So you can have really quite subtle behavioral responses.
Some of them are not subtle. You've just got to recognize them. That appeasement one is the classic. So many dogs bounce into my consulting room, and they are so incredibly excited. As far as the owner's concerned, they're incredibly excited to see me. It's very, Labrador. This is the usual Labrador, and the owner and I can see immediately their dog is anxious, and it's behaving highly anxiously. The moment I try and touch it, having given it plenty of time to get used to the room and used to me, it then starts doing this avoidance, appeasement behavior all over again. And the owner thinks it's just being super friendly and excited. It's painful, and it's trying to use this method of
strategy of, I don't want to be touched, but you like me anyway. Yeah. And
I see that is really obvious to me, but it's not obvious to most people because it just looks like a really excitable dog.
Yeah, or worse, they get told off because they're not sitting still. And it's really difficult being a vet in a small box consult room with very limited time, generally with a slippery floor, a table in the way, no windows, poor lighting. When we really put it all together, it's the worst environment in the world to be able to pick up on these subtle cues. And that's why educating owners is really, really important. So that they can come in and give us the goods. They can tell us what they're seeing, isn't it?
Can I tell you about my consulting room?
Oh, go on then.
The whole floor is covered in physio matting. It's amazing.
I like that.
And I have no table, and it makes it so much easier for me because I can basically grovel around on the floor on my hands and knees without hurting my knees. I can sit on the floor. I often end up sitting on the floor to consult.
Yeah,
that's off topic.
No, but I think it's really
grippy
it's really relevant. I think thinking about examining the dog on the floor, so they've got exit points where we put them on the table, and they're like, I don't know what to do. I'm just going to stand here and not move.
And that's when they inhibit.
Just pull off. Exactly.
And that's when they inhibit. And that's, so when we're talking about behavioural signs, and they inhibit any behavioural signs they're going to exhibit. So you then, as a vet, you go and examine every little joint, and twist and turn and flex and extend, and the dog says nothing. If you watch the dog's face, and obviously you might be doing this as the owner whilst the vet's examining it, you can see the dog's looking really worried, maybe licking its lips, looking sideways, as Hannah said, white of the eye. And sometimes you'll even see them grimace slightly. And if the vet's not looking at the dog's face, they don't see that, because they're having to look at what they're looking at. So you can, even during a physical examination, you as the owner can play a really important role in that.
Definitely.
You can say, he just pulled a really funny face, and he's licking his lips. I think he's really worried about whatever it is you're doing. And the vet should accept, appreciate that feedback.
Yeah, definitely. And when I've seen practice with like orthopedic surgeons and stuff, they're always watching every movement before they even plan on touching that animal. So they'll know it's the knee by the way that the dog's moved, sat down, stood up, laid down. They're like, oh yeah, knee, or lower back, oh it's neck, without touching them, because you get so much information giving them free movement. I have to big up Sarah Fisher here, actually, with her ACE work, her free work, and allowing a dog to move around in a safe environment and pick up information of how they move or how they choose not to move. Well done, Sarah Fisher, you're wonderful.
That came up the other day. How do you assess a dog that you can't touch? Was that with you? I was talking, was that on? Anyway, how do you assess a dog you can't touch? And yeah, Sarah Fisher, look her up. She's amazing. And
very good. We've done
an awful lot.
We've done about 3 lives with her now, I think 2 or 3 lives. So please go and type in Sarah Fisher into our search button, and you'll find them. Okay, so we've talked about how to kind of identify it. Let's now just quickly talk about identifying breakthrough pain, because we talked about this just before we went live, and how even me, who's super passionate about pain awareness, pain identification, I would have a gremlin in my head as an owner going, is it or isn't it? Am I making it up? Because some people planted some seeds of doubt in me when I had Holly, and they'd be like, oh, you're making it up, she's fine, you're being over the top, Hannah, and stuff like that. So I became a little bit cautious about how much information I told people, because they think I'm so paranoid. But what are people looking for with these breakthrough episodes? Give us some examples.
Oh, there's so many. I think if it's, so just using my favorite topic, which is end of dose failure. If we're getting breakthrough pain due to the medication dropping off too early for the next dose, or for a dose being missed, then you're going to see, if this is happening on a regular basis, you're going to see a pattern. So which is where keeping a diary, if you're not sure what you're seeing is real or not, keeping a diary is really helpful. Obviously, if it's just the single occasion you forget to give him his medication one day, then obviously the diary is not going to quite be the same. But it's still useful to keep the diary, because if you think you're noticing changes, but you're not quite sure, if you can start to see a pattern, or you can go back and say, oh, that day we were really busy, and I wonder if maybe we forgot his meds. So that, I think keeping a diary is really, really helpful. How else do you detect?
I think for me it was the understanding that it could be just a very short period of time. So as you say, it could be like an evening where they just get a little bit grumpy around about 10 o'clock. You're trying to get them to go to bed and they just seem unsettled. And it could be a small moment in a day, or it could be extensive periods where we're just not on top of the pain. The dog is consistently showing signs of discomfort, behavioral, physical, postural. And I think people need to understand there's a spectrum of possibilities. It could be a few hours on a regular basis. It could be long term, and the whole pain strategy and pain plan has got to be addressed. So just keep that in your heads, guys, and have confidence. As Gwen said, write it down. And if you're seeing a pattern, talk to your vet about it. It could be a simple case of juggling the meds. So give us a couple of examples, Gwen, because you do this a lot, don't you, where you just move things around a bit.
Yeah. So a classic one is my dog wakes me up at 5 a.m. every morning. And then I look at the medications the dog's on, and it's on an anti-inflammatory, non-steroidal anti-inflammatory, say meloxicam, for example, Metacam, Meloxicam, Meloxade, all the different names for that one. It's really common. Lots of dogs are on it, and it's on gabapentin. And then I look at how, so I say, so the owner says to me, it's on gabapentin. So I say, okay, how many times a day is it on gabapentin? Or twice a day? And so what time do you give that? So, okay, I give it at 8 a.m. and I give it at 8 p.m. Now I know that gabapentin only lasts 6 to 8 hours maximum. So 8 p.m, 6 hours, 4 a.m. Bingo. Your dog's waking. Hannah, you've disappeared. You're still
Hello,
there.
I'm here. I'm here.
And so 4 a.m, the gabapentin's running out. That's why your dog's waking you up, because it's feeling uncomfortable. It doesn't run out really suddenly, bam, suddenly I'm in pain. It's gradual. But then at night, pain always seems worse. So they go and wake their owner up. And the owner thinks, oh, does he need a wee? So you go downstairs, let him out for a wee. Doesn't really need a wee, but he goes anyway because he's quite likes your attention. Go back to bed, and he's still sort of nudging you to say, I'm really uncomfortable. And so we change the gabapentin to 3 times a day. So we then go 8 a.m, 2 p.m, 10 p.m. And all of a sudden he's not waking his owner up overnight. So that would be a classic example. And then another example is he seems really stiff on his walk in the morning. He doesn't really want to go for a walk. You have to get him out because I've got to go to work. So I drag him around the park, but in his evening walk, he seems much more keen. He's really happy. And then when I question them, I get my clients to tell me a story about the dog's day, and it's quite revealing. I literally say, okay, what do you do when you get up? And every minute little detail. And it turns out what happens is that they get up, they give the dog his breakfast and his painkiller, and then they come home, then they get their breakfast, and then they do various things around the house before they go to work. And actually the dog's gone all night without pain relief, as in, well, it had its last pain relief late last night, and then you've just given him his meds in the morning with his breakfast and taken him straight out for a walk before that new dose of medication is working. So if you can just switch it around, as soon as you get up, give him his medication and his breakfast, potentially. There's 2 anti-inflammatories that have to be given on an empty stomach, so maybe not give him his breakfast, it depends. And then you wait. Probably you do all of your morning routine, get ready for work, get your packed lunches ready, get the kids ready, and then you take the dog out once that medication started to work. Maybe take him with you on the walk to school instead of taking him out beforehand. And just adjusting little things like that. But we have to work with the client, with the dog owner, around their routine as well, because it's got to fit into your life. But actually most of the time, when I have these conversations with people, they can fit in a better routine for the dog. They just hadn't thought about the fact that medication doesn't work the moment the dog swallows it.
Yeah. And that's the thing. I think a lot of us do think that the medications are like light switches. Suddenly it's working. And they've got to, some of them have got to get through the gut, through the first pass hepatic metabolism. They've got to be metabolized into their active form. They've got to get around the body, get to the receptors, do their stuff. And that is going to take time. Talking about the morning thing is just a good chance for me to drop in an anecdotal story, which I love. It's not just also about medicating. There's also routines. And you just reminded me of a case where the owner's beloved dog was allowed to have lie-ins. So she would never want to disturb the dog, and the dog would eventually kind of get out of bed around about 10 and was stiff and uncomfortable for the whole day. And all we did, and it was just so simple, it was like, right, in the morning, get up, take a bit of food incentive, encourage the dog to go out for a wee in the garden, have a little mooch around the garden with your dog, incentivizing it if you need to, and see how we get on. Biggest difference. The dog was like, I'm moving, I've got rid of that horrible stiffness that really sets in overnight. I feel a little bit more fluid. I can take on the day. And that was no money whatsoever. It was just changing the routine. So have your eyes opened to subtle changes that can have a big, big difference. Cool. Okay, so another thing to mention, which we did talk about yesterday, is the clinical metrology instruments. Please, guys, there are tools out there. Canine Brief Pain Index, the inventory, the Helsinki Chronic Pain Index, Liverpool Osteoarthritis in Dog Study, client-specific outcome measures. There's many, many more out there. If you need help trying to identify pain and the severity, question yourself. Use one of these guides to ask yourself, because it can be really difficult going, oh, maybe I'm making it up, maybe I'm being over the top, maybe it's nothing really. They do exist, and we've done many lives about them and how they're available. But this is what I really want to talk about, is the toolkit. In that, me and Gwen were chatting before we went live about how cool would it be if every dog that is prescribed a medication, is diagnosed with OA, goes away with an acute flare toolkit, where owner's aware of it, knows that it is likely to happen, how to identify it, so that they're aware. So questionnaires, etc. And also questionnaires of what caused this flare. And I am at fault, being a first opinion practitioner, of not having the time in consults to really drill down with an owner going, okay, you've come to see me, your dog's got baseline pain, but you've come because you've seen a deterioration. What happened 48 hours ago? What happened 3 days ago? What did you do at the weekend? And we need to drill down why your dog's having an acute flare. We need to see if we can find the cause, because if we can find the cause, we can avoid it. Consults don't allow that. We just don't have the time. So this is why educating people online is really useful. But what other things would you put in the toolkit if you were kind of given a little box? They go away with a little box.
How to design your own client-specific outcome measures score,
Mm-hmm.
which is something that you can do on your own. You don't need the vet with you to design that, which is your own homemade, your own personal pain score for your dog to look at, to try and look at changes. But I'm just trying to think. So what goes in the toolkit? A list of get your vet to outline medication or to prescribe you what in human medicine they call a therapeutic pack. I discovered the other day.
Oh, that's cool.
Of a particular medication that can be used as an extra to what he normally has in an emergency when you've got a flare up, when you think you've got a breakthrough. And a classic one for that would be to prescribe Pardale to use just when the dog needs it for maybe 2 or 3 days to get sort of a burst of extra pain relief, or an increase in a dose of one of his medications. So that is the exception. There is the non-steroidal anti-inflammatory. If he's having an anti-inflammatory, that dose can't be increased unless you want a reduced dose. But the other drugs he's on, perhaps he's on gabapentin, he could actually possibly have an increased dose for a bit. But your vet needs to guide you as to how much you can increase it by, because otherwise what you'll end up with is a dog that's really lethargic and sleepy.
Yeah.
Which also is not very helpful, is it? Because it makes them stiffer.
More likely to trip, slip, stumble.
Actually asking your vet what you can do, what extra medication you can give him if he's having some breakthrough pain is really handy. So you don't have to just keep phoning the vet all the time saying, he's sore, what can I do? And then going in for an extra injection or something.
No, I totally agree.
Nip it in the bud before it gets that bad.
And I think that's really important as well, because so I'm doing some consultancy work for a company at the moment. I've been interviewing clients to get sound bites to put into the presentations. And it's really interesting interviewing clients that have now got some education and they look back and go, well, I wish I'd had that. I wish they'd done this. I wish they'd said that. And something that comes up quite a lot is just knowing that there are options. And one lady, I was cutting out a section today, she said, you can't, understand how important it is when the vet says, if this doesn't work, I've got other options. There's more in my toolkit. If we have a deterioration, it might be that we just need a little interim and then we'll be bouncing straight back. But those conversations just don't, sadly, we don't have the time. So in the toolkit, I think I'd definitely have an info. I'd have, this is our likely strategy. Nothing comes with a promise. Their acute flare plan might not be as effective as we like, and we'll have to think again, ready for the next one. But in my toolkit, I would put loads and loads of enrichment feeders. I would in the toolkit, it's a big box that's going to arrive in the post. So you've got your questionnaire, you've got your advice sheet, education booklet, but there's going to be a licky mat, there's going to be a Kong, there's going to be a snuffle mat, and there's going to be stuff that whilst you're having a flare, your dog can still have a nice time, and you can have a nice time because you see your dog's having an okay time. And some of the videos that I include in our talks are really simple things, like Holly had a cardboard box and her treats would be wrapped up in newspaper and the newspaper in the box. And she would just stand there picking out the newspaper, tearing it up to get to the treat. But she'd be weight shifting, she'd be leaning forward, she'd be stretching her neck, her brain would be distracted. I felt happy, she was happy. And we had that period of time of 7 to 10 days to let everything calm down again. And I think that's a really important thing for owners, because it is stressful.
And you need to, and the dog, if the dog gets bored whilst it's being rested because it's having a painful time, then that makes the pain worse. So if you're bored and anxious and depressed, your pain is worse. And we know that from human research and MRI evidence that the areas of the brain involved with anxiety and depression are all interlinked with pain. The areas of the brain that look at the process what we call the affective component of pain, which is how it makes you feel. So it's really important to make sure your dog is not bored and getting depressed.
Yes, and I would even go as far, and I'm going to go a bit hippie now, but I'm happy with it. I had a very strong emotional relationship with Holly. I'd have it with Luna, and if I'm stressed, I see they get stressed. So if I'm having a bad day, Luna is stuck to me like glue, but you could see she's like, what's going on? Is everything okay? What's gone wrong in your life? And her anxiety. So having just a toolkit to still have a good time, I think is really important. And the other thing, and this is quite a sad story, family rules. I know it sounds daft, but within a family unit, you can have people with very different attitudes towards how to manage that dog. And when we got an email one Christmas, it was so sad. This girl had written to Cam because she just needed to write to somebody. The whole family were at their house for Christmas. And she came downstairs and she saw that her distant family were throwing things across the kitchen floor for her arthritic dog to chase. And it was sliding everywhere and they were laughing. And she lost the plot. She lost the plot and screamed at the family during Christmas, and then ran up to her room and cried and wrote us an email. Oh my God, it was just so sad. But the family being a united force and not having different plans of actions or belittling somebody that is trying to do the right thing, I think is another thing. So we can put in our toolkit a fridge post. These are the rules. This is what happens. And everybody listen in. So yeah, I think a toolkit would be a really good idea. We're going to put it in the shop. That's what we're going to do. Cool. So the other thing to talk about is a bit more on the objective monitoring. So I think we had talked about the clinical metrology instruments, the questionnaires. We didn't talk about the new kids on the block, which are these accelerometers, these activity monitors. Do you use them?
I don't know. I think that we're getting more and more papers come out validating the various different ones that are available. There's quite a few available now, and some of the ones that have been developed to be a bit cheaper, because the original kind of gold standard monitor is called the Actical. It's very expensive. It's a research tool, and if you ever enroll your dog in a research study that requires an accelerometer and you get given one of these, they'll go through great lengths to make sure you give it back. It's really expensive. But there's some others that have been developed that are a bit more price pointed for the public.
Yeah.
And the various activity monitors, some of them are combined with a GPS. They tend to be a bit more expensive. But so some of them have been validated against these gold standard monitors, and there are a few that have turned out to be really quite reasonable in their activity counts, step counts, a bit like a Fitbit.
Yeah.
It goes on the dog's
I thought that they one use is to try and find the trigger as well, because if you can look back and go, well, actually, what were you doing 2 days ago, 3 days ago? And if you've seen that they've actually done a huge amount more exercise, you could actually never know. It might be because this finding the trigger, I think, is really important.
Yeah.
I think with people so concerned about vet fees and the cost of pet care, instead of just keep going back to your vet for the top-up meds, he's bad again. Well, actually, let's what is the source of this deterioration? So yeah, activity monitors are another thing. Having just mentioned reassessment with the vet, that is our next category. And we mentioned this yesterday. There's a real tendency that once an animal has arthritis, whenever they have a downtime, when they've had a deterioration, it's almost, oh, there you go, it's his arthritis again, let's ramp up his meds and see you later. Where actually we should be making sure that we haven't got a comorbidity. So can you give people some kind of examples of things that you've seen?
I'll try not to use the heartbreaking ones, but so I think I mentioned yesterday, didn't I, a really common one in my cohort patients, which are mostly elderly, is for them to have an infection somewhere. And either that infection is painful and that pain is worse than it would be normally if it was a dog without osteoarthritis that had that infection, or if the dog's got some sort of cognitive change, dementia, senile dementia, that infection actually then makes their dementia worse, which makes them appear worse from an arthritis point of view. And so it's really important for the vet to examine them and rule out that as an infection somewhere as a cause, or an injury even that's nothing to do with their arthritis, or
the ear disease was the one that I mentioned. The dog had otitis externa, and we were thinking, oh God, the arthritis is deteriorating. And we're like, wait a minute, actually, this is a new finding. Let's treat this, because the dog had a really quite profound dip in their pain control.
Yeah,
but it would have been easy to overlook it.
Or an infection in the joint. So this is the other one that is actually really common, even for and for vets to miss, is that the arthritis in the joint appears to get worse, but it's got suddenly worse, and it's just really odd. You can't identify that the animal's injured themselves, haven't overdone it, but suddenly this particular joint has got hot and swollen and really painful. And if you've noticed hot and swollen, you need to mention it to the vet. And this is where the vet definitely needs to examine the dog. And obviously that's been really tricky in the last 18 months with the pandemic. We've been doing a lot more teleconsults. And when you've gone to the vet, you've often had to just hand your dog over to be examined rather than go in with them. So there's been a tendency not to examine dogs and to prescribe, more medication. But always the vet will be saying, if that medication doesn't help, then I need to see the dog, and we need to do a clinical examination to work out that there's not something else going on. And it's rare. I will emphasize that it's rare, but I have had examples of animals coming to the pain clinic. I always insist that it's a vet that refers them, because I want a vet to have examined them before they come. I've had animals referred by physios, and I've said no, it has to be a vet referring. Not because I don't respect physios, but actually, my most recent example, the dog turned out to have a bone cancer. But because the vet looked at the dog, because I said, yeah, the vet has to look at the dog before it comes to see me, the client didn't have a wasted trip to see me, but then got packed off promptly to a place that could treat the bone cancer. So, which, I wouldn't have been able to do because I don't have, a radiotherapy unit at
No, absolutely. I think we just have to keep our minds open. And I think the sad truth is a lot of people think fate wouldn't give you 2 blows. You're already managing one condition. It's unlikely you'll get another. The law of probability, that don't exist. There is a strong chance that your dog could have 2, 3, or 4 conditions. So reassessment is really, really important. I'm going to quickly mention about the multimodal approach, and then we'll do pharmaceutical action plans after that. So there's so many lives about the multimodal, guys. Multimodal basically means using many different interventions to have a successful optimal output. So it comes from the world of anesthesia, where you use different medications. So you use smaller amounts of multiple medications, therefore reducing the risk of adverse events, and have a more successful anesthetic. Well, the same concept. If we have some weight loss, we have got rid of the ball chucker, the dog stops jumping out the back of the car, we've put some rugs down in the house, we've got on a non-steroidal and we're using it very successfully as designed for that non-steroidal certain time every single day with or without food. And we've introduced some hydrotherapy. Wow, we've got so many different avenues covered. And much of what Cam suggests to people is free of charge. Lots and lots of these lifestyle changes, exercise adaptation is free of charge, and it can have a massive impact. And we're going to talk about exercise in a minute. So please don't forget the importance of the multimodal approach. Back to pharmaceuticals. How can we encourage people to use them more appropriately? Because you do a brilliant talk, which I've seen many times, where you kind of say the obvious, but I think a lot of people are a bit scared and just don't think about it. Giving owners a medication plan that they can actually do.
Yeah.
Is important, isn't it?
Yeah, so I spend an awful lot going beyond the non-steroidal anti-inflammatories. Actually, I'll come back to that in a minute. And thinking about one of the adjuncts that we sometimes add on to an anti-inflammatory, and gabapentin is an example. I'm always saying to vets, has to be 3 times a day. It's got to be 3 times a day. It's not useful twice a day. And then I'm going, except a lot of people go out to work and they can't dose at 3 o'clock in the afternoon. So what then? Because, okay, maybe you have a dog walker come in and they could dose. Maybe they could dose at lunchtime. Okay, that's reasonable, as long as your dog walker's happy to do that. So we can work out how to do that. But and then I've got other clients who say, from a family point of view, the middle part of the day, it always gets forgotten. It almost always gets forgotten. And then they realize at tea time they didn't have the lunchtime dose. So now we do. So then I'll just try and adjust. We can potentially try a different, instead of gabapentin, try a different one called pregabalin, which is quite a lot longer acting, and so we can just go down to 2 times a day, which fits into most people's routines better. So that's an example of trying to fit into the routine. And then
ease of delivery, tablet versus chewable versus liquid
syrup, or different methods. And then some people just cannot get medication into their dog. They've managed to get the dog food averse by trying to force it to eat its dinner with disgusting tablets in it. And then they just physically can't. So for whatever reason, they can't pill their dog. So I've got a client with rheumatoid arthritis, and she cannot, some days she can't get down, excuse me, she cannot bend over to get down to this little dog to give it its pills. And she just can't do it. So then we start looking at what other options have we got. And there's quite a few options coming out now. This year's been amazing for new medications.
This year's been incredible, hasn't it?
We've got a once monthly injection for arthritis called Librela, which is currently on a bit of a short supply, unfortunately. And the early experience with that has been incredibly positive. So that means that the owner's not got to remember to give a non-steroidal every day. We've got longer acting non-steroidals come out. So this actually, Daxocox is the one that has been the sponsors of today make this one called Daxocox, which is once a week. So that for people who can't manage once a day, that's going to be really, really helpful. Or they just can't manage the routine to remember to do it. I mean, we need various ways to get people to help to remember, like things like Dosset boxes when it gets, if it gets quite complicated, that can help you to remember to give a medication every day. And yeah, as you said, syrups and things instead, so injections instead of pills. Some of the anti-inflammatories are more palatable than others. Some dogs will actually voluntarily eat them. And then
so all of these things are kind of like, choose a strategy that is going to be able to be stuck to.
So I always, have a slide in my talk these days, is that whatever plan we make with the client, we don't make the plan for the client. The vet has to make the plan with the client. It's got to fit into the client's capabilities. And I use a slide, which is a picture of an elderly woman in an armchair with a little dog on her lap. And this lady can't walk her dog. So she's reliant on a dog walker. And that she can't bend down to give pills to her dog. So we've got to figure out how we can help her medicate her dog within her own capabilities. It's no use just saying to this, because this client's not going to say, I can't manage to give it 3 times a day. She's going to go away saying, the vet knows best. I've got to find a way. And then she just won't manage to do it.
That's why, picking up nurses here, and this is something that Cam can help you with, is nurse clinics.
They pick all this stuff up way better than vets do.
There's actually a paper out saying that nurses are more sensitive to pain because they listen more. Vets have a tendency to control the conversation and direct it, and maybe that's time pressure. We've just learnt to get in there, guide the conversation, get it done. Whereas nurses are much better at listening. So if you as a practice are thinking, oh, this is all very interesting, get a nurse clinic sorted and we can help you. So there you go, me and Gwen. So no, I think that's really, really important to make sure that if we're going to be using these pharmaceuticals, we've got to make sure that we give them every opportunity to be used as they are designed to be used. But just looking at time, there's a little bit more that we wanted to cover. This section is called Action on Breakthrough Pain. And I just wanted to kind of like reinforce the fact that we really do need to start thinking, what is triggering these breakthroughs? Incident, idiopathic, end of plasma levels, what is going on that's allowing these breakthroughs? Because everybody's going to be happier in that most owners, they'd rather go to the vet and the vet say, okay, so in these transient moments of discomfort, what we can do is juggle the meds around. Stay as we are, not adding more meds. We're just going to move them around. Or actually, the meds that you're on are okay, but I'm going to give you one to use just short term. An owner will be like, really? Brilliant. So what? 5 days? Fantastic. I'm happy with that. Because most owners do not want to give medication consistently. So we do need to try and look at the underlying cause to try and facilitate that. And Larry Driver, MD, is quoted as saying, whenever possible, correctable causes of breakthrough pain should first be addressed. And I think that's really, really important.
Well, it's the old adage of prevention is better than cure, isn't it? If you can identify the trigger and then prevent it happening again.
Exactly.
Save a lot of pain, heartache, and money.
Definitely. So that was something I just wanted to mention. But now the topic that there is no answer, and exercise. So I created a crib sheet for this tonight, and I couldn't actually abbreviate this section because it's just there aren't answers yet. So I wanted to just kind of like read a section of something that I pulled out. and leave it with you guys to think about it. So although evidence is emerging to support reduced acute pain from an exercise session with adherence to neuromuscular exercise programs, so a physio program, it is unknown whether such programs should be continued whilst in the midst of an acute flare. So somebody said yesterday, should I continue to exercise as I am during an acute flare? And at the moment, we don't know. We're not sure. Because there's lots of different causes for the flare, especially in dogs, because they haven't told us the pain is definitely localized to the joint. I know it's definitely a flare-up of my osteoarthritis within my joint. It could actually be associated pain, soft tissue pain, myofascial pain, a secondary source. And that could actually do really well with exercise. Moving is important for myofascial pain, and keeping them sedentary is the worst thing you could do for that. So a good examination is definitely important, but we still are not 100% sure whether to keep them moving in a reduced, low impact way, or to restrict them quite firmly. And this is from human work. There's nothing out there in dogs, I can assure you. Depending on the underlying cause of the flare, resting the joint in the short term, such as using knee braces, modifying painful activities, may limit joint loading and help with tissue healing. Whether complete rest or reduced volume distribution of load is needed remains uncertain, and how to determine the appropriate course of action when a flare-up occurs without understanding the etiology is difficult. Further advice regarding trigger avoidance for OA flare-ups is more challenging, because the impact of exposures are not well understood and are likely to evolve insidiously. Now, this is where I get really excited, and Gwen's going to giggle. Low-level, non-traumatic over time could actually play a role. So we always think of acute flares as going to be acute, sudden onset, impact, stress the tissue in an explosive, violent way. But actually, they're saying, well, it could be a build-up of micro-trauma, slips. See where the flooring comes in here.
Going up the stairs.
Going up the stairs.
I'm sorry, I'm interrupting your flow, but one of my clients who's actually a veterinary nurse, she's great because she does the sort of not noticing there's a problem, and then all of a sudden she goes, light bulb moment, this is what the problem is. She took her dog on holiday and it was brilliant. Really, she was really, really comfortable. Came home, all of a sudden she's uncomfortable, and she suddenly realised the dog's doing the stairs. There were no stairs on holiday.
Oh.
Carry on with your flow.
Yeah, no, I like that. Okay, so cumulative low-level microtrauma in response to repetitive or aberrant mechanical loading is thought to be central to osteoarthritis etiopathogenesis. Although strength and control through exercise is beneficial for joints and may potentially reduce acute pain due to exercise perturbations in local joint stress, it could also hasten flare-ups. If some flare-ups are the joint's response to mechanical load, do subsequent inflammatory responses lead to further joint damage and need to be stopped or shortened? Or are flare-ups the joint's attempt to restore homeostasis and they're therefore necessary? Now, this is something that blew my marbles, but it makes a lot of sense. Inflammation is tissue healing. We need a degree of inflammation to heal tissue. And there's us, as soon as we have an acute flare, quell it as quickly as you can. Welfare. And are we actually supposed to allow a little bit? Because it's actually encouraging tissue healing is what they're trying to say. So I don't want to confuse people, but basically there's still so much that we don't know. And what is so important is that people educate themselves, try different things, monitor the response, and start finding your path. So you might find that your dog during an acute flare comes out the other side a lot quicker when you really do reduce the exercise. You use your licky mats, your snuffle mats, 5 to 7 days, shorten those walks to just pee walks, and you come out of that flare pretty quickly. Or you might find actually your dog does really well having, just reduced exercise, but still going out, still moving that tissue, still keeping them up and going. And unfortunately, we don't have all the answers, and you guys are going to have to try and find it out, and we can only but support you.
And what I would really say, though, is it's really worth seeing a physiotherapist.
Mm.
A skilled physiotherapist will look at the whole dog, and make a really good treatment plan, and then give you some home exercises to do. And if your dog has a flare up or some breakthrough pain, they can then give you some extra advice about some things you can do at home to keep that joint moving, because we know that keeping the joint moving is really important, but it might be you want to do that in a non-weight bearing way.
Yeah.
A physio can show you how to do that. Or, there are other professionals that have qualifications to help with that. But I'm a great advocate for physiotherapists.
Definitely, me too. And I'm one of the converts that I never really thought about it before. I've been a vet for 20 years and I only got obsessed with arthritis 8 years ago. And I had never really thought about it. It wasn't taught. So I need to just read this last bit to you, because this is why we've had 2 days about breakthrough pain, acute flares, why it's important that we identify them and try and minimize their occurrence. And this is going to hit home hard. Conceptually, occurrence of flare-ups, their frequency, predictability, and time to episode resolution may diminish organ reserve, the capacity of an organ to return to homeostasis after the challenge. So that's basically saying the more flares that we have, we're just running out of steam. We're going to burn out the joint quicker. Understanding aspects of flare-ups that may contribute to reducing organ reserve would be important to mitigate long-term adverse effects. A model of a diminishing organ reserve would complement the characterization of osteoarthritis as a disease of organ failure. So what they're just saying there is that it is part of a management plan to start working out why we've got breakthrough. And if there are triggers, especially incident triggers, it's really our duty of care to try and avoid them. So this, guys, let's be blunt, kicking the football, tennis ball, if your dog is then having periods of deterioration after that, you're just speeding it up is what it's likely to be doing. So changing lifestyle has a massive impact. It's worth doing. Don't just plug in the drugs and ignore everything else. It doesn't work like that. Anything else to add, Gwen?
I think you should check if there are any questions, because look at the time.
I know, totally. Okay.
I don't have anything to add at this stage, because I've chipped in as we've gone along, and I think we've covered so much.
So here's one from Julie. If a dog pants heavily, could this mean they are in pain?
Yeah, it could do. It could also mean that they're hot.
Yeah.
I think what's normal for your dog. I think if you're noticing an increase in the amount of panting they're doing, or if there's particular timing, so you've taken them out for quite a slow walk on a nice cool day, which wouldn't have made them pant a lot in the past, and you get about 10 minutes into the walk and you notice they're panting and licking their lips quite a lot, and maybe slowing up as well. That could be pain, as in at the start of the walk he was doing all right, but actually now it's getting a bit uncomfortable, and you realize that we need to deal with that and potentially go for a shorter walk. So panting could well mean pain, yes.
Yeah, definitely. This is way exciting. Ready for this? Somebody from Colombia. Whoop whoop.
Hello.
We get really excited when we have different countries come and join us. So thank you so much, Roger, for saying that you're from Colombia. Anybody else that's listening, tell us where you are. We want to know. Recently got an email saying that we're big in Russia. So that's cool, isn't it? But yeah, let us know where we're reaching. This really hits home for me. 2 consecutive dogs with extremely complex pain issues. Been very lucky to have had professional support throughout via vets. I don't know who VB is and Cam, but the daily worry never goes away, as in how much do we allow them to express their natural behavior, which can be counterproductive for pain. It's difficult. I totally feel you, Boo. It is really hard knowing what can you let them do, but what do you know with hindsight is going to actually leave them more uncomfortable. And it is your journey, it is your pathway, and you can only just do the best. Okay. So we've got any more? Oh, we've got loads of people telling us where they are, which is lovely. Oh, James. All right, James. He's been on here. We do like James. We're not doing the stairs or unlevel ground now, and brambles is much better. Brilliant. I love it. Got this one. A superb vet physio is treating my Shepherd Cross with knee arthritis at 2 years old. Been making much improvement with exercises she sends and laser alongside massage. I believe Harriet has made a tremendous change to Gandalf's pain relief. Perfect. Go physios. This has been so helpful. Thank you. We've been in a real muddle about breakthrough pain, and you've really helped our understanding. Yes. So actually, you only need to type in James Hunt into our search. You'll find a Facebook Live about pain scales and objective monitoring, because we did one about a year ago. So please go and look that up. So we've got Canada, we've got Lancashire, we've got New Zealand, we've got Ireland. Wow. Slovakia. I love this.
Awesome. New Zealand, that's early in the morning, isn't it?
That's early. It's South Africa over here too. Brilliant. Really, really cool. So thank you guys. So that's us. I would like to say thank you to our sponsors, Animal Care. Really, really fantastic to start getting companies behind what we do. So thank you, Animal Care, for having faith in us to deliver good content and giving us the opportunity to talk about something that needs a lot more attention. Animal Care are the manufacturers of Daxocox, which is a new non-steroidal that has a 7-day duration of action. So it might be part of your toolkit. We don't know. You know, you are on your journey with your dog. But thank you very much, Animal Care, for sponsoring this event. Thanks, Gwen. How cool are you? As said, I'm going to do a blatant plug. Me and Gwen work together quite a lot. We do lots of practice trainings. And if you would be interested in our services coming to your practice, then please just get in touch to info@caninearthritis.co.uk. Until next Tuesday, we have, I think we're going quiet for a while, but next Tuesday, we've got the amazing Mark Lowry talking about tremors, trembles, and any of those kind of movement patterns that you think to yourself, is this neurological? Is this pain? What's underlying this? So hopefully we'll be able to lift some of the confusion about those. It's going to be intense. I've got something like a 12-page paper that he's written to read. It's going to be tough. So get ready for next Tuesday. It's the last day of the big walk, guys. So thank you to all of you that did attend. It's been an absolutely wonderful event, and we're hoping to make it annual. But thank you for that too. See you later then. Take care.
Bye.